Okay, so this is an interesting case of a chap in his 60s who has had two previous malignancies, a cholangiocarcinoma and also resection of a colorectal cancer. He has had a left hepatectomy for the cholangiocarcinoma and has re-presented with biliary obstruction because of previous surgery, including hepaticojejunostomy. He does not have a conventional endoscopic approach to accessing his biliary tree, and so he has had two right-sided internal-external biliary drains inserted. The challenge here is we don't have a diagnosis. We are presuming that this is a malignant recurrence at the anastomosis. Okay, so tissue is the issue, and the more tissue you have, more techniques to get tissue you use, the better the chance you have of making a diagnosis. I don't think we push hard enough to make a tissue diagnosis in patients with biliary strictures. Now, clearly this case is an unusual one because we're doing the procedure percutaneously rather than via a standard ERCP, but actually the rules remain the same, and in fact I think that our radiology colleagues perhaps don't push hard enough to make a pathological diagnosis, and there's no reason why they couldn't use this technique, which is the Steris Infinity brush. The particular features of this brush, which we may have discussed, are that it has three bristles, stiff black set of bristles at the tip, the same stiff bristles at the back. The aim of that is that they excoriate the mucosa and allow a better cellular yield, and then the soft white bristles in the middle then capture those cells. I'm inserting the brush over an 0.035 wire and into the liver through the peel away sheath into the right posterior ducts. The sheath is curved beautifully around the corner there. Excellent. So now I'm going to open the brush actually across the hepaticojejunostomy in the small bowel, just so I don't traumatize anything with the tip of the brush. Screen, please. And let's slowly open the brush.
Yep, opening.
Nice. Nice, nice, nice. And as we open the brush, I'm coming back with the catheter.
Opening.
Yeah, beautiful.
Opening.
Okay, excellent. And so you can see the radiopaque marker at the tip of the brush, and then the end of the catheter sheath, also radiopaque, 4 or 5 centimeters further back. And I'm just going to just a little jiggle backwards and forwards here, right across the abnormal tissue at this patient's anastomosis. That's very good, and this brush proceeds beautifully across this stricture. That is actually really nice. Okay, let's close the brush. Okay, so we've done the brush with the Steris Infinity brush, and that can be incredibly important to make a diagnosis of malignancy. We have to be honest, however, that in every setting, a tissue biopsy that includes the local architecture allows the pathologist to much more reliably give us a diagnosis of malignancy or exclude malignancy, because with a biopsy they're able to look for invasion. And so biliary cytology is important, but I think if we can make a histological diagnosis or take histological samples, that's always an important thing to do. Whatever technique you use to make a histological diagnosis, whether it's a surgical resection or an endoscopic biopsy, the bigger the tissue, the more likely you are to make that diagnosis. And that's particularly true within the biliary tree. We have over the years used fluoroscopically directed endobiliary biopsies, so essentially putting standard biopsy forceps up the bile duct. That is technically challenging often, particularly biopsy forceps out of the bridge of the duodenoscope and then into the through the ampulla. That can be challenging, and there is a definite concern and a risk of trauma, including bile duct perforation. And a way to very significantly reduce that risk is if you're not just blindly or fluoroscopically passing the biopsy forceps, but doing it over a wire. And that's where this Steris Histoguide comes in. You can see that we've loaded this biopsy forceps on the wire. You will have seen in other videos that the forceps is secured to the wire just below the biopsy cup, and it allows us to smoothly advance the biopsy forceps into position. And again, you see this coming into position. I think this is a technique that we need to encourage our radiology colleagues to do more of. Now, I would just say that if I was doing this biopsy simply through the sheath and not over the wire, at this bend that we're approaching, there would be almost no chance of the biopsy forceps going around that bend, and there would be a risk of causing trauma. So we may cause trauma and we wouldn't reach where we need to biopsy. That's avoided with this technique. Screen, please. I'm just going to advance a little bit further. Beautifully round the corner there. Can we open the biopsy forceps, please? That's good. So you can see those jaws opening beautifully there. And close. And I've got a little tug there, which I like to feel. Good. Lovely. That's come out there. The other thing, the other obvious advantage of this technique is that you can go backwards and forwards, taking multiple biopsies. Yeah. Without the repeated anxiety about cannulation or reaching the stricture safely. Have we got decent biopsies? Nice samples, good. Okay. Okay, so in conclusion, I think that's a good procedure. I think we've really targeted this this stricture. I don't know what the diagnosis is yet. Certainly, we've taken lots of biopsies, including Steris INFINITY brush and Histoguide biopsies. So I think really pushing to make a pathological diagnosis. Good. Thanks so much.